Okay, imagine this for a second. A condition that affects maybe up to 1 in 50 people across the whole world.
That's a huge number.
It really is. And here's something else: women are about twice as likely to get it. We're talking about rheumatoid arthritis,
Hmm.
where your own immune system starts going after your joints. Have you ever had that kind of joint stiffness that just lingers? Or maybe you know someone dealing with that persistent joint pain.
It's surprisingly common when you start asking around.
Totally. Well, stick with us because in this deep dive, we're going to really unpack what's going on with rheumatoid arthritis and, crucially, how physiotherapy can actually make a big difference.
Yeah, we're drawing on a pretty comprehensive presentation today,
Yeah.
which gives a really solid base for understanding RA and, importantly, how physiotherapy fits into managing it.
Exactly. So our mission today, for you listening, is to explore that physio angle for RA. We want to shed light on how specific approaches can, genuinely relieve pain, help stop those deformities from developing, and just generally improve how you move and function day to day.
And we'll try our best to keep the heavy medical jargon to a minimum, make it accessible.
Definitely.
Now, before we really jump in, we do want to give a quick shout out and a special thank you to London Heartbeats Z Academy in the UK.
Oh, yes.
They're doing great work in education, especially in areas like this. They've got a huge range of courses, actually, I think over 150 popular ones. We really encourage you to check them out.
Yeah, definitely worth a look.
And you can find them on social media too, Facebook, Instagram, YouTube. Give them a follow, subscribe. They offer free, regular updates, and you won't miss out on future discussions.
Great stuff. Okay, so rheumatoid arthritis, RRA. It's clearly more than just standard aches and pains, isn't it?
Oh, absolutely. The material we're looking at defines it clearly as an autoimmune disease. So think of it like your body's defense system gets confused and starts attacking its own healthy tissues instead of, say, viruses.
Right, friendly fire, essentially.
Kind of, yeah. And fundamentally, it's also a chronic inflammatory disease. Chronic meaning it sticks around, it's ongoing, and inflammatory meaning there's that persistent swelling and irritation, mainly hitting the joints.
And it's not just one joint acting up in isolation, is it? The source mentions it affects connective tissues all over the body. That sounds systemic.
It is systemic, that's the key point. Connective tissue is everywhere, ligaments, tendons, joint linings, so the effects can be really widespread. That's why the information rightly calls it potentially crippling and disabling.
Crippling and disabling. Yeah, those are strong words. And it seems to hit women more often, about 2 to 1, and typically starts from age 16 upwards.
That's correct. The higher incidence in women is, well, a well-established fact in ERA. And yeah, the onset, often being in younger adulthood, means can have a really long-term impact on someone's life, their work, their activities.
Okay, so let's zoom in a bit. What's actually happening inside the joint? We hear about this uncontrolled inflammation. What does that actually look like?
Well, the process described is quite specific. This constant inflammation leads to what's called an exuberant proliferation, basically, an overgrowth of the synovium.
The synovium, that's the joint lining, right?
Exactly, the thin membrane lining the joint capsule. This overgrowth forms a sort of invasive tissue called a pannus.
Pannus. Okay. And what does this pannus do? Is it just extra tissue?
Unfortunately, no. This pannus is quite aggressive. It actively invades and starts destroying the nearby bone and cartilage within the joint. That's the primary mechanism of the joint damage you see in RA.
Wow. So the inflammation triggers this growth, and the growth itself causes the destruction. It's a vicious cycle.
It really is. And the damage isn't always just confined to the bone and cartilage. The source also points out that tendons, ligaments, even blood vessels around the joint can get caught up in this inflammatory process too.
Which probably explains the range of symptoms people feel.
Precisely. That wider involvement contributes to everything people experience day to day.
Which brings us to the clinical signs. The things someone with RA actually notices, the info lists stiffness, tenderness, pain on movement, those sound pretty common for joint issues.
They are, but often more intense or persistent in RA. Swelling is another key sign, a direct result of that inflammation. And over time, this combination can lead to, well, visible joint deformities and real limitation in how much you can actually move the joint.
The source also mentions extra-articular manifestations. That means symptoms outside the joints themselves.
Exactly. Because it's systemic, RA can affect other parts of the body, lungs, skin, eyes, heart, blood vessels, and it specifically mentions rheumatoid nodules.
Nodules, like bumps.
Yeah, firm lumps that can form under the skin, often over bony areas or pressure points, like the elbows. They're quite characteristic of RA in some people.
Okay, so if someone's having these issues, stiffness, pain, swelling, maybe these nodules, how do doctors figure out if it is RA? Is there like one single test?
That's a great question. And no, there isn't usually one single definitive test. The diagnostic criteria outlined in our source show it's more about putting together a puzzle based on several factors.
Okay, so what are the pieces of that puzzle?
Well, first off, morning stiffness. But not just any stiffness, it needs to last for at least an hour after waking up. That prolonged stiffness is a big clue for inflammatory arthritis.
An hour. Wow, okay. What else?
Swelling, actual fluid or soft tissue, swelling in 3 or more joint areas at the same time.
3 or more. And does it matter which joints?
Often, yes. Swelling specifically in the wrist, hand, or finger joints is another criterion. Those small joints are very commonly affected in RA.
Right.
Then there's symmetry, arthritis affecting the same joints on both sides of the body.
Ah, okay. So both wrists or both knees, for example. That makes sense if it's the immune system involved. What about those nodules?
Yes, finding those rheumatoid nodules can also be part of the diagnostic picture, and then there are blood tests.
Right, like for rheumatoid factor.
Exactly. Looking for abnormal levels of rheumatoid factor, or RF, in the blood.
But it says abnormal levels, suggesting it's not always a simple yes-no from the blood test.
That's a really important nuance. You can have RA without having RF, and some people without RA might test positive for RF. So it's suggestive, but not conclusive on its own. It's a piece of evidence.
Got it. Anything else?
The final piece mentioned is X-ray changes. Seeing evidence of bone erosion or destruction around the joints on an X-ray. But importantly, these changes often only show up in later stages of the disease.
So diagnosis is really about the clinical picture, the symptoms, the pattern of joint involvement, maybe the nodules supported by blood tests, and sometimes X-rays, especially over time.
Precisely. It's a careful clinical evaluation.
Okay. Now, the information shifts to how RA actually affects movement. The pathomechanics, how the disease messes with how we walk and move.
Yeah, as the joints get inflamed and damaged, it inevitably impacts movement patterns. The source details common gait deviations, changes in walking. Things like decreased velocity, so walking slower, lower cadence, meaning fewer steps per minute, and shorter stride length.
Smaller, slower steps. That seems logical if you're in pain or stiff.
It is. It also mentions a poor heel-toe pattern. Normally, you strike with your heel, roll through, push off your toes. That smooth pattern gets disrupted.
Right.
And people often develop abnormal weight-bearing patterns, shifting their weight to avoid stressing painful joints.
And it doesn't just affect the walking pattern itself, but can lead to other issues in the feet and legs. It lists quite a few things here. Genu valgum, hallux valgus.
Yes, these are common problems that can either develop because of RA or get worse. Genu valgum is knock knees, where the knees angle inwards.
Okay.
Hallux valgus is what most people call a bunion, that deformity of the big toe joint.
Right.
Then you have pronation of the foot, which is excessive inward rolling, depression of the metatarsal heads. Those are the bones in the ball of the foot. They can kind of drop down.
Ouch. And it also lists hammer or claw toes.
Yeah, those are deformities where the smaller toes get bent into fixed abnormal positions. Very uncomfortable.
Yep.
And finally, it mentions tendocalcaneal bursitis, inflammation of the bursa behind the heel, and subplantar spur formation, like a heel spur. All these foot problems can really impact mobility and cause significant pain.
It really shows how the initial joint inflammation can cascade into these broader biomechanical issues. Okay, so moving on, the source briefly touches on conventional medical management, the drugs used.
Yeah, this is a vital part of controlling RA. The main categories listed are NSAIDs, non-steroidal anti-inflammatory drugs. Think ibuprofen or naproxen. They help with pain and inflammation.
Standard stuff for inflammation.
Right. Then crucially, there are DARDs, disease-modifying antirheumatic drugs.
Disease-modifying. So they do more than just manage symptoms.
Exactly. DMARDs, like methotrexate, for example, aim to actually slow down the disease process itself, reduce the immune attack, and prevent or limit further joint damage. They're really a cornerstone of RA treatment.
Gotcha. What else?
There are also immunosuppressants, which more broadly dampen down the immune system response. And corticosteroids, powerful anti-inflammatories, like prednisone. These are often used for short periods to control flares quickly.
So a range of medication options depending on the situation. But sometimes medication isn't enough or other problems arise. The source mentions surgery. When might that come into play?
Yeah, surgery isn't usually the first step, but it becomes an option for several reasons. Persistent pain that isn't controlled by meds or therapy is one.
Okay.
Worsening joint function, like if you can't use your hand properly anymore.
Yeah.
Progressive deformity that's interfering with life. Also, persistent localized synovitis, that's stubborn inflammation in one joint lining that just won't settle.
Right, that panis thing, maybe.
Potentially, yeah.
What?
Also, if a deformity becomes irreversible and causing major issues. More urgently, things like an actual or imminent tendon rupture,
Whew.
nerve entrapment, like carpal tunnel syndrome, which is common in RA due to wrist swelling, and even stress fractures. If bones weaken or mechanics change drastically,
So reserved for more severe or complicated situations, generally.
generally, yes.
Which brings us nicely to the main event for today, physiotherapy management. The source really flags this as a key component.
Absolutely essential. Medications tackle the disease process, surgery addresses severe damage, but physiotherapy focuses on function, pain relief, and quality of life day to day. It's incredibly important.
So how does a physio approach RA? It starts with assessment, right? What do they look at?
Yeah, the evaluation is key. They'll assess posture, as you said, because RA can really impact how someone holds themselves.
Hmm.
They'll test muscle strength and power. Identifying weaknesses is crucial. Measuring joint range of motion, how far each joint can move.
And gait analysis, checking the walking pattern we talked about.
Exactly. And then functional tests.
Yeah.
These look at how RA impacts real life, things like balance, walking ability, but also ADLs, activities of daily living.
ADLs, like getting dressed, managing the bathroom.
Precisely. Can they do these basic tasks independently? This assessment builds the full picture.
Okay, so once they have that picture, what are the goals of the physio treatment?
The goals are really focused on improving life with RA. Firstly, protecting the joints from further damage, that's huge.
Makes sense.
Providing pain relief, obviously very important. Preventing deformity development where possible. Preventing long-term disabilities.
So minimizing the negative impacts. What about improving things?
Definitely. Increasing functional capacity, what someone can do. Improving flexibility and strength. Encouraging regular, safe exercise. And boosting overall general fitness. It's about empowerment.
Okay, let's talk specifics. What techniques do physios use? It mentions cold therapy first for acute phases.
Right, cryotherapy. Using cold packs or ice. The source suggests about 10-20 minutes, maybe once or twice a day. Yeah, thermotherapy. Using heat packs, warm water, things like that. Usually for longer, maybe 20-30 minutes once or twice a day, when things are less acutely inflamed but still stiff and achy. Heat helps relax muscles, increase blood flow, ease that stiffness.
And it mentions normal skin temp is around 33 degrees C, but can go up to 36 degrees C with inflammation.
Yeah, it's an interesting detail just highlighting that measurable heat increase during inflammation.
Okay. Next up, 10 ENS, transcutaneous, electrical nerve stimulation. How does that fit in?
10-ENS uses mild electrical currents via pads on the skin. It's mainly for short-term pain relief, the source says, maybe 6 to 18 hours.
How does it work?
It's thought to work in a couple of ways, maybe by blocking pain signals to the brain, maybe by stimulating the release of natural painkillers, or by reducing muscle spasm. The source notes it can improve soft tissue elasticity and is sometimes used before exercise to make movement more comfortable.
That sounds useful, getting over the pain barrier to actually move. Now, exercise itself. The source splits it into acute and chronic phases. What's the approach during a flare-up, the acute phase?
During a flare, you have to be gentle. The focus is on maintaining movement without aggravating the inflammation. So gentle assisted movements through the available range, basically, keeping the joint moving without forcing it,
Okay.
and isometric contractions. That means tensing the muscles around the joint without actually moving the joint itself, like pushing against an immovable object or just tightening the muscle. This helps keep the muscles active and maintain some tone without stressing the inflamed joint, usually done at least once daily.
And then when things settle down into a more chronic, stable phase,
Then you can gradually progress things. Introduce light resistance exercises to build strength back up, work on postural exercises and core stability. That's really important for supporting the joints.
right, taking the load off.
Exactly. And bringing in cardiovascular exercise. Things like swimming, walking, cycling are often good choices as they can be lower impact. Plus, gentle stretches for tight areas, like around the knees or the calf muscles.
It sounds like a balancing act, keeping active but not overdoing it.
It absolutely is. And the source emphasizes why regular exercise in general is so important.
Hmm.
Maintaining muscle strength is key for joint stability and preventing injury.
Mm.
It explains how pain, swelling, and just reduced activity can actually inhibit muscles, making them weaker,
Mm.
and also how prolonged positions or being immobilized can shorten muscles,
Mm.
making them tight and limiting function. Exercise helps combat all that.
Breaking that cycle, the source includes a general image of body stretching here, just reinforcing that flexibility point, I suppose.
Yeah, maintaining flexibility is crucial for keeping joints moving as freely as possible.
Okay, another big area. Joint protection strategies. This sounds like practical, everyday advice.
It really is. This is about modifying activities to reduce stress on the joints. Things like avoiding staying in one position for too long.
Right, get up and move around.
Yeah, and consciously balancing activity with rest. The key advice here is to rest before you get overly fatigued or sore, not pushing through the pain, learning to pace yourself.
Listening to your body.
Definitely. It also suggests reviewing your work or home desk setup, basic ergonomics, making sure your chair, desk, screen are positioned well to minimize strain.
Good point. Especially if you sit for long periods.
And during those acute flares, consciously minimizing high-stress activities, like if stairs really aggravate your knees, maybe try to limit trips up and down when things are bad.
Really practical stuff. It also briefly nods towards common deformities, though it doesn't detail them here. That's a whole topic in itself, I guess.
It could be, yeah. Preventing or minimizing those deformities is a major long-term goal of good RA management, including physio.
And finally, it lists some alternative therapies. Tai Chi, music therapy, yoga, relaxation, Pilates.
Yes, these are often used as complementary approaches alongside conventional medicine and physio. They can help with things like flexibility, balance, stress reduction, pain management, and just overall well-being. They might not change the underlying disease, but they can really help people cope and feel better.
So wrapping this up, it feels like physiotherapy offers this really comprehensive toolkit for managing RA, doesn't it? It's much more than just exercise.
Absolutely, that's the key takeaway. It's a multifaceted approach using cold, heat, TNS, specific exercises tailored to different phases, joint protection strategies, education, all aimed at relieving pain, protecting joints, and keeping people as functional and active as possible.
And for you, listening in and understanding these principles, whether it's for yourself or someone you know with RA, it's empowering, isn't it? It gives you tools and knowledge to be proactive about managing the condition and improving quality of life.
Definitely. And considering how complex RA is, this interplay between inflammation, joint damage, movement, it does make you wonder, doesn't it? What other holistic approaches, maybe beyond the standard physio and meds, might hold potential for long-term well-being in managing this condition? Something to perhaps think about as you continue learning.